Specialty Story, session number 43. Whether you're a pre-med or a medical student, you've answered the calling to become a physician. Soon you'll have to start deciding what type of medicine you'll want to practice. We're here to tell you the stories of specialists from every field to give you the information you need to make sure you make the most informed decision possible when it comes to choosing your specialty. Welcome to Specialty Stories. My name is Dr. Ryan Gray, your host here every week, where we bring you a great specialist to talk about his or her specialty. And this week is no different. We have Dr. Venkat Gangadharan, who is a community-based interventional cardiologist. And we're going to talk all about interventional cardiology, how he got interested in it, what he likes about his job, what he doesn't like about his job, and so much more. Let's go ahead and jump right in and find out how Dr. Gangadharan first fell in love with cardiology.
First of all, I knew I wanted to be a cardiologist right in my second year of medical school. And I did whatever I could to figure it out. Any book that I opened up, cardiology was like the only chapter that I read. And I tried to make my way with everything else, by learning from somebody else. And by the time I got into residency, things changed. The first 2 years of residency, my mind did change. I had an idea of whether pulmonary critical care or cardiology would be my calling. And then I got the chance to experience what the cath lab was like and finally see what they do when they treat heart attacks. And I was pretty much sold right then. I'm a guy that likes instant gratification when it comes to treating patients. I like to see them get better right then and there. And that's where I found, one, doing cardiology, number two, doing interventional cardiology was the way to go. I knew in my second year that I wanted to do interventional cardiology, second year of cardiology fellowship, that is, and did whatever I could, applied everywhere across the United States. And let me tell you, it was the toughest thing because no matter how competitive you are, you're one amongst several thousand that are trying to get the same position. And I must have interviewed in at least 10 different places, and it was so difficult that I finally ended up matching in a program just at the last minute and made the decision to take it. And I feel, that was the greatest decision ever. And I feel good about it.
What was it about cardiology? You said you opened up the textbook and you loved reading and learning about cardiology. What was it about cards that drew you in?
It was the, the physiology behind it. Everything made sense. There was a reason for why, the heart did what it did. There was a reason for why the rhythm was abnormal and what we did to fix it. And, it required some amount of, cognitive thinking, some amount of problem solving. But at the end of the day, there were defined medications for certain purposes. There were risk factors that you knew that you could treat, and there was problems that had a definitive treatment modality and a cure for some extent. I figured that doing the job that I do, it would be far easier if I had a plan, a defined plan, one that I knew makes sense, and one that I could easily explain. I'm a lot about working with my hands. I'm a lot about the mechanical aspect of things. And when you're looking at your heart, it's essentially a pump. It's essentially a box that has valves and has different mechanics to it, and it only works a certain way. And the medicines and things that we do make it work that way. Other specialties, not that I wasn't drawn to them, but things like oncology and infectious diseases and gastroenterology, it just, the breadth of knowledge required to be a specialist in them and the problem-solving nature in them just didn't appeal to me as much as cardiology did. And to be quite honest, reading those textbooks, it was the only thing that ever made any sense.
What traits do you think lead to being a good interventional cardiologist?
I think you need to be dedicated. You need to be hardworking. You need to be analytical and be able to think on your feet. When you're in the cath lab and you have a patient's life in your hands, there are probably a million different decisions that are running through your head, and you just got to be able to pick and choose the right one and make sure the patient gets through it no matter what. In the modern day, when it comes to heart attacks, the chance of people dying from a heart attack is so low nowadays that everybody gets a chance. Back in the day, when interventional cardiology was in its infancy, many people didn't get that chance because there was no facility to treat them, there was no place to send them, and that's how we discovered thrombolytics and a number of different medications. But now, with the technology that we have, there's not one person in this entire country that should not have a chance to live, but at the hands of a cardiologist. And so, when it comes to traits, I would say you need to be able to think outside the box, be able to be analytical and mechanical in your head, because interventional cardiology is all about physics. Interventional cardiology is all about the give and go and trying to get either a stent in a place that needs to be stented or a valve in a place that could be replaced without any difficulty.
The way you were talking about being in the cath lab with somebody's life in your hands, do you need like emergency medicine and trauma medicine, whether you're a trauma surgeon or a ortho trauma guy or gal, do you need to have that adrenaline junkie kind of mentality as well?
I would absolutely say so. I mean, when you're taking a STEMI call, which is what we call emergency call amongst interventional cardiologists, if you're not able to wake up on an instant in the middle of the night at 3 o'clock, after you've had a long, hard day, to have all of your faculties ready to go, and you drive the 20 or 30 minutes to the hospital that you need to go serve, and then have your fingers ready to go and adept to put the stent where it needs to go or fix the blood vessel that needs to save a person's life. I mean, you need to love the rush for you to be able to have the mental faculties to take care of that problem and in the wee hours of the night.
You're in a private practice setting. What was the decision algorithm for you to go private practice versus an academic setting?
Well, coming through fellowship, although you train in an academic setting, you never really get or understand the experience of what an academic interventional cardiologist really is, because at the end of the day, what you're trying to do is get your skills and understand the concept of things and be confident in what you do, no matter where you go. The reason why I chose private practice was, number one, it was the easiest choice at the time. There are far more private practice positions out there than there are academic positions. Number two, you have to have a certain mentality and a certain persona to be an academic interventional cardiologist compared to one who's a private practice physician. In this day and age, they say that is being a doctor money driven. I wouldn't say that it's money driven per se, but I would say that it plays a huge role in the decisions that you make when it comes to the job you pick and then the way you want to raise your family. As a private practice physician, you have the ability to dictate your own life, the ability to treat your own patients, the ability to learn things at your own speed without having to really answer to anyone else but your own practice. And that was kind of what I was looking for to start with, because to me, I felt in private practice I would get the most opportunity to make my skills as great as they are before I decide to choose a different avenue.
As a interventionalist, what types of pathologies, what sorts of diseases and patients are you seeing?
We see everything from valvular heart disease, including like aortic valve stenosis or mitral valve regurgitation, to atherosclerotic vascular disease. It's truly mind-boggling the amount of coronary artery disease that is out there and how young a person can be by the time they get affected. And to be quite honest, it's humbling when you have to do a intervention or treat a STEMI in a 34-year-old when you're 34 years old as well and are living the same kind of life that he is. It opens up your eyes. It makes you want to realize that life is short and you need to take good care of yourself. And so when I see things on the screen, sometimes it uh, makes me just think twice, because it's surprising to see how bad people's arteries could be at such a young age.
Think twice when you're eating that burger.
That's right. That's right.
Describe a typical day in the life of an interventionalist.
So as a private practice physician, as I said before, it's tough to be just an interventional cardiologist. And so what I do is I practice a lot of general cardiology as well as interventional cardiology, but my mind is always focused on what I can do to fix something. And so the way my day runs is I get to the hospital around 6 or 6:30 in the morning. I round up my patients during the day. And if anyone comes in with a heart attack or I'm on call for STEMI, I drop what I'm doing and go and save that life, followed by, going to the office and going to the clinic and trying to recruit patients to your practice so that you can maintain a lifestyle and maintain a career. And again, treat these patients the same way. The interventional cardiologist, it's very rare in private practice to find a position where you do just interventional cardiology. You just have to be ready to handle any situation that's presented to you. As in my particular situation, I take emergency call about 3 to 4 times a week. And that's because I'm a young doctor and my practice is made up of only 2 interventional cardiologists. And so we handle the brunt of everything.
What does that call typically look like?
From an emergency call perspective, you'd be on call about 3 times a week. But not all private practices are like that. The larger the private practice, the less call that you're going to take. And from a general cardiology perspective, I take call once a week, and then I do 1 weekend a month. Initially, when I first started out all this, it was pretty rough going, because I never thought it would be this much work. But, you get used to it. Like I said, that adrenaline keeps you going. And to be quite honest, talking to you right now, I'm actually on call for one of the hospitals.
Oh, wow. Hopefully we don't get cut off.
No, I think we'll be all right. Yeah.
Do you feel, with all of that call, being a younger doc, do you feel like you have enough time for life outside of medicine, whether you have a family or other activities that you want to do?
And that's the $1 million question. Over the past 3 years, I can be quite honest. I have, thought about what life outside of my work and the balance that I have between my work and my home life. I have a 2-year-old son, and I can tell you, when I come home every day, it puts a smile on my face when he calls me dad or says he wants to play with me, and misses me all day long. But there are plenty of days that I have where I feel bad about coming home late or working as much as I do. But at the end of the day, you being young and being a young physician, this is your career. This is the time to make a living. This is the time to earn for your family, after which you can decide what's going to work for you and where you want to spend your time more.
Yeah. And the more time you have under your belt, hopefully the less call you have to take and the more seniority you'll have.
Exactly.
What does the path to becoming an interventional cardiologist look like, residency and fellowship training?
So, once you come out of medical school, you make the decision to do an internal medicine residency, wherever that may be. Typically, when I was applying, I looked at places that had a decent cardiology fellowship, because I knew that was what I was going to do. And then the likelihood of you getting into the cardiology fellowship at the residency program that you trained at is better than one you would get it at another place. Following which, you do another 3 years of a cardiology fellowship. During that time, you're introduced to cardiac catheterization and different aspects of interventional cardiology, at which time, around the 2nd year of that fellowship, you make the decision that you want to become one, and you start to apply to interventional cardiology fellowships. Now, the difference between interventional cardiology fellowship applications and the general cardiology fellowship application is that many of those programs are, paper applications, meaning you have to seek them out, find out what their application process is, do every step that you can, and then apply. And then, of course, follow up several times to see if they've received your application, and try to hone in on the programs that you really want to be a part of. At the end of the day, they look at a number of different things, which is degrees of research that you've done during fellowship, your progress through your testing during fellowship and training, and of course, at the end of the day, where you trained. That goes a long, long way.
Why do you think matching into interventional is so competitive?
I think it's because, to be quite honest, it's one of the more rewarding of cardiology fellowship in my regard. Not that I have anything bad to say about being an electrophysiologist or being a nuclear cardiologist, but for some reason, when people decide to become a cardiologist, the one and the number one killer in people in the world is heart attacks, and so an interventional cardiologist is essentially designed to treat those. And so you figure that the amount of people that are applying to be an interventional cardiologist are far more than the people applying to be an electrophysiologist or a nuclear cardiologist. And from what I understand, becoming an electrophysiologist is very, very difficult. The testing is very, very difficult. And it really requires someone to be a very cerebral and sort of a mentalist to handle that kind of a profession.
The adrenaline junkie versus the mentalist.
That's right.
I like it. From your standpoint as an MD, do you see any negative bias towards DOs who want to get into interventional cardiology?
I don't see that. And to be honest, in my own practice, I have a partner who's a DO, and he took a very long way to become what he is today, but he's a successful interventional cardiologist, and there really isn't any bias. At the end of the day, the MD and the DO designation is just a designation. The person you are is the physician that you are. What kind of training you get is what kind of training you get. So you can be an MD and be an awesome physician. You can be a DO and be an awesome physician. I don't think that has any weight in terms of whether you have a chance of being an interventional cardiologist or not. I think it's what you do with the time that you spend and the training that you spend that makes you who you are.
Once you are fellowship trained in interventional cardiology, are there any other opportunities to further subspecialize?
Well, recently there's a new development in something called structural heart disease. And in the country, there's only a handful of programs that are actually accredited structural heart disease fellowships. The ACC as well as the ABIM have yet to recognize a designated fellowship for this. In addition, coronary artery disease is not the only thing that plagues people. Peripheral vascular disease is also what plagues people. And so there are specialized fellowships to do a training in endovascular work, is what it's called, where you treat abdominal aortic aneurysms, you treat claudication or blockages in the arteries in your legs, as well as people with carotid artery disease or strokes. You have the possibility to access those blood vessels. I mean, when we call ourselves interventional cardiologists, we're actually an interventional cardiovascular physician. And so the vascular aspect of things is largely untapped, and majority of that training can be obtained after a fellowship. And so those are the other avenues that are available right now. Hopefully in the next few years, they become designated fellowships and there's more opportunities out there, and people start to do them more.
It's funny you mentioned that. I spoke to an interventional radiologist previously, and it sounded like with interventional radiology, there was a development of some turf wars. And the way you describe kind of the cardiovascular aspect of interventional cardiology, it sounds like there may be some turf wars brewing with vascular surgery as well. Is that true?
I'm going to say that's absolutely true. When it comes to peripheral vascular disease, it's actually a turf war between a vascular surgeon, an interventional cardiologist, and an interventional radiologist. Mm-hmm. And unfortunately, there are programs out there that have long trusted the interventional radiologist to do the procedure, or long trusted the vascular surgeon to do the procedure. And we as interventional cardiologists are right now making the push to take that on ourselves. I mean, the breadth of peripheral vascular disease is so prominent in this country. There's opportunities everywhere, but you won't see many private practice interventional radiologists or private practice vascular surgeons doing a lot of endovascular work. Majority of them have some sort of academic affiliation. you will see a lot of private practice interventional cardiologists handling all that work.
Interesting. What do you wish you knew primary care physicians knew about interventional cardiology, what you did day in and day out to better help their patients?
I would say that I wish they knew the breadth of disease that we see, the complicated nature of disease that is present in their patients. And at the end of the day, I really wish they would understand the medications that we use to treat these conditions. Unfortunately, I live in a place where managed care is a strong push in this area. And what I mean by managed care is that primary care physicians are limited in the medications that they can offer their patients. And many of them end up changing the medication that I place my patients on, or denying the stress test or denying the arterial ultrasound that the patient needs to, gather some more information for their complaints that they have. And when I first got here, it blew my mind that this was a process and that was reality. And over the 3 years, I still cannot grasp this idea where primary care physicians literally dictate a patient's life, regardless of the symptoms that they have. It's almost like a patient has to show up in the hospital to get the real care that they deserve, then go through their primary care physician because, maybe 6 times out of 10, they're going to get denied. And it's very sad because I've had to rescue people at the, at death's door when they could have been rescued maybe 2 years earlier without that problem.
Wow. That's not fun.
That's not fun. That's not fun at all.
Which is why we're undergoing healthcare change all the time.
Agreed.
What other specialties do you work the closest with?
I work very closely with pulmonary and critical care because they help manage my patients in the ICU, as well as I help to treat pulmonary hypertension that is often diagnosed by a pulmonologist. I work closely with infectious disease because they have a large breadth of people with, foot ulcerations or diabetic foots and such that require peripheral vascular interventions. I also work very closely with nephrologists because when it comes to uncontrolled hypertension, it's a mixture of ideas from a cardiologist and a nephrologist, and sometimes an interventional cardiologist is needed because renal artery stenosis is another atherosclerotic problem, another blood vessel in the body that can be stented, which can help reduce your blood pressure. So I work quite closely with those 3 specialties, and they, rely on me to help them as well.
There are some specialties that I talk to, some physicians who their specialty lends them to going into other non-clinical aspects of medicine, whether it's going into industry or going into administration. Is there anything special about interventional cardiology that lends itself to having opportunities outside of clinical medicine?
I think the more senior you become as an interventional cardiologist, I think even the more senior as you become as a cardiologist, the opportunities outside of medicine start to open up. When you're part of a large hospital system and you have a good relationship with the hospital administration, most of those avenues are open for you. Speaking of my group, one of my partners is actually the chief of internal medicine in the hospital, as well as the chief of cardiology at the hospital. And it's a rotating door when it comes to that position, but cardiologists are often taken in high regard because we, to be quite honest, have our fingers in every aspect of things. In addition, from a research perspective, there are cardiologists out there that have migrated over to industry. My mentor himself has left practicing interventional cardiology after about 45 years and is now fully engulfed in industry and promotes one of the products that he helped design and help bring to market and help bring to its position today. And so you have the opportunity to migrate over to industry and be a speaker like yourself and go out and teach the world about what you do.
What do you wish you knew going into interventional cardiology that you know now?
I wish I knew what the process was to get better trained in what I do. To be honest, I feel like I probably should have seeked out an extra fellowship, like a structural heart disease fellowship or a peripheral vascular fellowship at the end of my 1 year of interventional cardiology. But at that time, you make the decisions based on the situation that you're in. And if I had known that there were so many opportunities out there, I probably would have given it a better shot. It never really occurred to me at the end of my fellowship. And number two, I would say that although I'm a private practice physician, I wish I had given academic interventional cardiology a strong push at the time that I was making a decision for a job.
It's never too late.
It really isn't. And I never knew that it was going to be this busy. And but I'm a young guy. I'm pushing through it, and hopefully something turns out in the next few years.
What do you like the most about being an interventional cardiologist?
I love doing procedures. I love working with my hands. I love the adrenaline rush of fixing a heart attack. To me, waking up at 2:00 in the morning is not difficult. And if I could save a life and they walk out the door the next day alive from something that could have killed them, I feel like I've done my job for the day. To me, the procedural aspect of this whole profession is what makes it the best thing every day.
What do you like the least?
The bureaucratic aspect of it. I think running a private practice or trying to develop a career as a private practice physician is very, very difficult. Unless you have the business know-how or the business acumen, I would say, it's difficult to make yourself well known in a community that has several people just like you. Does that mean that you shouldn't try? No, I think it's always a good thing because it really teaches you what the business of medicine is like. To be quite honest, one of the things that we lacked as residents, as fellows, is that nobody ever told you what the business of medicine was like. Nobody ever told you what reality was like. And reality is that everything costs money. Everything you do, you need to earn something from it. And you need to be happy doing what you do on a day in, day out basis. And so you need to find a place that gives you the opportunity to grow as a physician, but also gives you the security that you know that this job is going to keep you happy for years to come.
Do you see any major changes coming to the field, whether it's medications or new procedures?
Well, there are several new changes coming through, but one of the biggest changes that will likely be coming through over the next year or two is that CMS is going to be bundling payments when it comes to cardiac procedures and cardiac diagnoses. And what I mean by that is that, for example, myocardial infarction, which used to be differentiated regarding the medications that you prescribed and the procedures that you did and the stents that you put in, are now all going to be bundled under one big heading called myocardial infarction. So the payment that you're going to get is going to be far less than what you would have gotten in the past. Over the last 5 years or so, cardiology has been largely affected by the reimbursement and the cut in reimbursement. I mean, we've lost almost, I would say, 40 to 50% of what the normal reimbursement would be for a regular procedure. And that's why, it's now becoming more and more cutthroat in our field to do more work and find more patients and treat more disease because you're not making as much as you used to. And so that's only going to get worse as time goes on. Eventually, private practice is likely going to dissipate depending upon where you live, and hospital-employed physicians and hospital-employed practices are going to predominate in this country. And the reason for that is that hospitals can negotiate better deals with insurance companies, hospitals can negotiate better deals with pharmaceutical companies than a private practice ever will. And if you want to keep doing what you're doing and want to make a decent living, you might end up becoming a hospital-employed physician. I'm going to hold out as long as I possibly can, but it's just around the corner.
So CMS, if you're listening, don't know that, the Centers for Medicare and Medicaid Services. I briefly want to chat about that for a second, since you brought it up. Do you think everybody is always up in arms about reduction in reimbursements? And obviously, as an interventional cardiologist, you've been out in practice now for 3 years. There's interventional cardiologists that have been out for 15, 20, 25, 30 years. You expect, or you come to expect, a certain level of income, and when that gets messed with, everybody freaks out. Do you think that these reductions in reimbursements are totally crazy, or do you think that now that interventional cardiology has been around a while, the procedures that they're reducing reimbursements for, the technology's been out for a while, and everybody kind of knows how to do it now, so it makes sense to reduce the reimbursement?
In my personal opinion, I don't think it makes any sense to reduce the reimbursement, because at the end of the day, these procedures are being done by physicians who are, one, taking the time out of their night to stay awake in order to save a person's life. The procedures continue to be arduous. They don't get any easier. Although we have technology that's available to treat these conditions, these procedures don't happen in 30 minutes. They take an hour, hour and a half. Sometimes peripheral vascular disease can take as long as 4 hours. And so the work, the stress, the difficulty with your general lifestyle all still exists, and that's never changed. Yeah. And so reducing the reimbursement for these procedures is unfortunately, fostering an environment or an idea that medical management is probably better than risking your own life trying to do something. I have seen a lot of my partners who were, interventional cardiologists back in 30 years ago when things were great, really changing the way they practice based on the reimbursement that they're getting. And it makes sense, because let me ask you this question: why would you go and try to do something, whether it be to save a person's life or to be good at what you do, when the government and insurance companies don't feel like it's necessary and don't feel like you should get paid for it?
Yeah.
I think that mentality is coming out a lot in our newer graduates. And the older generation is also catching up to it and realizing that they can't make as much as they used to. And so it's throwing a big stress in many of these private practice groups. I can tell you, the idea of newer graduates to think that, they're going to get paid like they did 30 years ago, it's never going to happen.
Yeah.
Like I tell everybody that I meet, if you want to be an interventional cardiologist, you're doing it because you love what you do. You're doing it because you love being a cardiologist. Don't do it for the money, because it's happening everywhere.
Yeah, that's every field. That's right. Every specialty. I think that's good wisdom. If you had to do it all over again, would you still choose interventional cardiology?
120%.
Nice. And any last words of wisdom for a pre-med or medical student out there thinking about cards, thinking about interventional, to motivate them, after we had a discussion about how they're not going to make any money, to motivate them to continue down this path?
Cardiology is a specialty that is going to continue growing. It's going to continue being the most prevalent disease in this entire world. What I would advise medical students and the people listening to this podcast, I would tell you that if your heart is in cardiology, if you
pun
think
intended.
That you want, no pun intended, and if you truly believe that you want to help people, and that adrenaline rush is what you live for, interventional cardiology is the way to go. You're going to love working with your hands. You're going to love the awesome equipment that we use, and it's only getting better. I mean, you can do things with our heart arteries that people couldn't even fathom 30 years ago. And think about it, we still have 30 to 50, I still have like 30 more years in my life, and all of you are going to have 50 more years in your life. So the things that you're going to be doing, I can't even believe that is going to come out. And research just keeps happening and happening. And so if you love cardiology, if you love what you do, and you live for excitement, you're not going to be disappointed.
All right, so there you have it. Again, that was Dr. Venkat Gangadharan talking about private practice, community-based interventional cardiology. I hope that was helpful for you. Our first cardiologist on here on the podcast. I hope to bring you many other subspecialties within cardiology so you can get a great picture of what cardiology looks like possibly for you in the future. Again, that's our goal here, to find all of these different specialties and talk to them in an academic setting, in a private practice or community-based setting. Find out what their job is like so that as you are going through your training, you get a better picture of what life for you will look like. You'll hear why physicians are choosing their specialties, what they like about it, what they don't like about it, and that will help guide you on your journey to choosing your specialty. I hope this week was helpful for you. Join us next week when we have another great guest for you here on Specialty Stories. And don't forget to recommend this podcast as well as all of the other podcasts that we have, including the Pre-Med Years, the MCAT podcast, and Old Pre-Meds podcast, as well as the Shortcoat podcast over at mededmedia.com. That's MEDED media.com.